First and foremost, we have transit for fluid from the extracellular space, and I think it is a reasonable thought to believe that no matter what the pathology we're dealing with, whether it is lymphedema or a vascular structural anomaly, there will be some associated tissue edema as part of the presentation of the patient. So, with transit of fluid from the extracellular space, we have the ability of the lymphatics to help to maintain fluid homeostasis. As we discussed yesterday, there is an important role, a vital role actually, in the absorption of gastrointestinal lipids, and finally, trafficking of antigen-presenting cells to the lymphoid organs. And I believe Dr. Zavea will be addressing some of this importance in his talk to follow. So this is another view of something that we showed yesterday, which is to have an idea about the overall organizational flow at an architectural level within the lymphatic tree. Of course, the lymphatic tree begins with the so-called initial lymphatics, these blind-ended sacs that directly interdigitate with the interstitial space by virtue of anchoring filaments that hold these structures directly in apposition to the interstitium. And of course, this part of the anatomy is designed to maximize the convection of fluid and cells and macromolecules into this space. And this occurs in part because we have what are called the button-like junctions between the cells. So the lymphatic endothelial cells have this kind of oak leaf cluster structure in which the overlapping edges are held together by tight junctions, but in between there are interendothelial cell flaps that can open and close to allow the rapid transit of materials into the lymphatic structure. And these are sometimes conceived of as the primary valvular system of the lymphatics. So when the lymphatics, in fact, have two, and the second set, of course, are present in the lymphangiomas themselves, in which there are delimiting lymphatic valves that allow each segment of the collecting vessel to operate as an organizational unit. And in this portion of the tree, there are not the button-like intercellular junctions, but rather what are called zippers. So in other words, the tight junctions are cementing the cellular material together completely because, of course, by this point, it's a solid pipe that's supposed to be carrying fluid back to the heart, and we don't want any leakage back out of that structure. And of course, there's a smooth muscle cell coat to provide the ability to have both the intrinsic and extrinsic contractility that we heard about yesterday, and eventually all of this will lead the contents of the lymphatic to the node for the immune processing that, again, we'll hear about later. There is a defined role in human disease of all varieties for all of this structural and functional substrate. So let's start talking about the situation in health. So I showed this slide yesterday, I believe, and it illustrates the difference in structure between a blood vessel and a lymphatic vessel. Just briefly to review, the blood vessel has a continuous basement membrane, and it is characterized by the presence of adjacent pericytes, in contradistinction to the lymphatic vessel, which has a discontinuous basement membrane. It's in the collecting portion of the vessel, it's a little more concrete than it is at the level of the lymphatic capillary. There are the anchoring filaments that I've already mentioned, and the purpose of all of this is to create the ability for transit of fluid and macromolecules passing through the interstitial space to gain re-entry into the lymphatics, to allow for absorption of lipids in the gastrointestinal tract and perhaps in other regions of the body, and again for the traffic of these antigen-presenting cells. So the lymphatic vessels are start out as a capillary network that merge to form the conducting vasculature of the system. They resemble veins, but their walls are quite thin. The valvular density is much greater than is seen in veins. And of course, we have the interposition of lymph nodes that allow it to perform, the system to perform its immune function as well. So a gross anatomic view of the lymphatic system, and you can see, although perhaps it might be a little bit difficult to read some of the legend here, most of the system bears a name for our purposes, not necessary to delineate all of this, simply to say that the organization is not haphazard and each of the nodal bearing areas are well defined, and the general route of flow between the nodal bearing areas and back to the heart is also well defined. As we get a little more granular about this, we can see that specifically when we're talking about the head and neck region, there is a specific anatomy related to the right side of the head and the right arm compared to the rest of the body, all of which feeds into the thoracic duct. So here is that anatomy shown in more of a schematic form. The right lymphatic duct, which is not always emphasized as such, drains into the right internal jugular and right subclavian veins. So again, feeding this one right-sided upper quadrant of the body, with the remainder of infradiaphragmatic flow and flow from the left side of the chest and arm and head and neck all into the thoracic duct, which eventually will drain into the subclavian vein, the left subclavian vein. And just to reemphasize that the cisterna chyli represents the inferior extension of the thoracic duct at the junction of the diaphragm. So just to reemphasize a little more, the lymph drainage of the head and neck, because this becomes very important, specifically in the setting of lymphatic vascular malformations, which as isolated lesions preferentially affect the head and neck. We recognize that we have these deep cervical lymph nodes that surround the length of the internal jugular vein and ultimately drain all of the lymph from the head and neck. And there are outlying nodes that will have received most of this lymph flow prior to its secondary appearance in the cervical nodes. The outer circle is made up of superficial nodes from the chin to the occiput, and the inner circle lies within it, surrounding the upper airway and the alimentary passages. As we think about the upper limb, again, we have a very distinct anatomy for the arrangement of the lymphatics. The superficial lymphatics will arise from the thumb, index, and lateral part of the hand, following the cephalic vein to the infraclavicular lymph nodes, and from the medial part of the hand, it will follow the basilic vein and ending up in the lateral group of axillary lymph nodes. The deep lymphatics follow the arteries and progress to a lateral group of axillary lymph nodes. While it's not specifically a topic of today's session, rather yesterday we talked about lymphedema. Obviously, this anatomy is of great importance when it comes to breast cancer therapeutics, because herein lies the risk of developing upper extremity lymphedema with harvesting of axillary nodes. And there is now increasingly an interest in doing a reverse lymphatic mapping to determine if the sentinel node for the arm can be defined as distinct from the sentinel node for the breast in order to spare the likelihood of developing lymphedema. As I showed yesterday, this pattern of initial lymphatics and initial collecting vessels are then spread out diffusely throughout the skin and superficial layers as defined extensively by 18th and 19th century anatomists, as in this drawing from the 19th century. Until recently, we had reason to believe that there were no lymphatics in the central nervous system. That was the dogma, that the cerebrospinal fluid, in fact, subserved the function of the lymphatic vasculature outside of the cranium. But more recently, in mouse developmental studies, it has become clear that, in fact, what you see here in red, just adjacent to the mouse dura, are, in fact, lymphatics inside the central nervous system. And in fact, This has led to a reorganization of our thinking about lymphatic anatomy, and we now can claim the central nervous system along with everything else. So again, getting a little more granular, and again, we discussed this a little bit yesterday. This is the overall organization from a structural functional vantage point, and I'm grateful to my wife for this illustration. Here we have the initial lymph sacs, or sometimes one can call them capillaries, and there is shown schematically here the overlapping relationship of the endothelial cells that allows for rapid entry, and eventually these will coalesce into pre-collectors, which become collectors once they are invested with the lymphatic valvular apparatus and with the smooth muscle cell coat, and then progressing to distal points within the anatomy. So the lymphatic system contains all of these structures in this general order, starting with the formation of lymph and progressing onward all the way to the lymph tissues and organs. I did show this slide yesterday, so I won't dwell on it except to point out the fact that we have 68 trillion lymph capillaries in the body. The overall lymphatic system comprises about 3,500 kilometers of real estate, and there is a total flow of 2 million milliliters in terms of total lymph volume. This is what the collecting vessel looks like under the light microscope. You can faintly make out the fact that this represents a single lymphangion subtended by unidirectional flow across two adjacent lymphatic valves that you can see there briefly. And this shows the functional organization of these lymphangions in a sequential fashion so that the emptying of one lymphangion into the one more proximal will then lead to its distension and activating forces to cause the contractility of that lymphangion. Of course, this requires the sequential opening and closing of the valves in an appropriate fashion in order to prevent reflux of lymph in a retrograde direction. This movie is courtesy of Dr. Zavieja and shows you what that contractility looks like in real terms, and you can see both the frequency and the amplitude of the lymphatic contraction of an isolated segment of a collecting vessel. And then looking in an immunofluorescent context, you can see again, evidence of the valvular structures and nicely outlining the lymphangion based upon specific staining of the lymphatic endothelial cell. So this again is the schematic of the function of a single lymphangion. Clearly the distal valve needs to be closed while the proximal valve is opening, and the action of the smooth muscle cell on the underlying lumen is to extrude the contents from that lymphangion into the one above. Again, a whole mount preparation to show you really how elegant this valvular apparatus is and its ability to control the forward movement of fluid. And once again, a review of the fact that we have these primary valvular relationships among the lymphatic endothelial cells of the capillaries, which ultimately will progress into the zipper-like junctions so that fluid is retained within the collecting vessel and progresses toward the heart. The lymphatic capillary is designed to allow the entry of all of the constituents that we want to be in there. Just to illustrate where the lymphatic vasculature is found within the skin, because again, the skin is a target organ of damage in these diseases, and Dr. Dadras will be telling us later more about the pathology of the conditions, but here you see the relative position of the lymphatic capillaries within the mid-portion of the dermis and below, and you can see the relationship to the blood vascular structures. So this is what it would look like schematically in a cutaway view, and you see a structure that inversely resembles the loop of Henle in the kidney. This looks like a mirror image of the kidney, and you can see where the lymphatic vessels reside in proximity to the vasculature. Again, immunofluorescence staining to show you not only the intimate relationship between blood vasculature and lymphatic vasculature, but also the relative sizes of the lumens. And this, of course, is related to function as well. So this is a slightly more active immunofluorescent examination because it actually shows you that when we inject fitsidextran, which is a large molecule that both fluoresces and is large enough to require lymphatic uptake from the interstitium, we outline, you can faintly see the adipocytes that are surrounding these lymphatic vessels, but you see residual dextran within the tissue itself, and then you see the fact that it has been taken up by the lymphatic capillary. Notice that where the arrowhead is, that's a blood vessel. This material is impermeable to the blood vessel because it cannot enter the vessel by diffusion, and I think this very nicely illustrates the functional capacity of lymphatics to deal not only with fluid, but also with macromolecules. I did show this slide yesterday again to show in cross-section the distinction between an arteriole and lymphatic vessels. You can see the isolated lymphatic endothelial cells studding the surface of the vessel, here in a slightly higher magnification, and even higher magnification under scanning microscopy. You can see the irregular lumen and again the endothelial cells on the surface. This is to show you what the anchoring filaments look like. Remember that these are the structures that anchor the lymphatic capillary to the surrounding interstitium so that the intimate relationship between the interstitium and the lymphatic can be maintained. These are structures that have a thickness on the order of nanometer dimensions, and you can see they look very much like parachute strings. One simple conception about how this system operates is that as the interstitium collects fluid, it will distend and in turn cause distension of these filaments. These filaments, by being attached to the interendothelial cell openings, will actually cause the openings to open and will allow then convection of fluid into the lumen, which is here. As the interstitium becomes emptied of the extra fluid, the filaments will become loosened again and the interendothelial openings or primary valves will close. So just a little bit of overview related to disease. You will hear about more of this in the clinical session should you choose to remain. I hope that you do. So this is an example of pulmonary lymphangiectasia. Just to emphasize simple concepts, ectasia represents an abnormal size and associated function of a normally located and normal number of lymphatic vessels, but this would be a congenital vascular malformation, and you can see here the large openings that represent these ectatic lymphatic vessels. And the lung parenchyma underneath, because of the lymphatic dysfunction, is underdeveloped with thickening of the alveolar septi. Here you see the really abnormally dilated subpleural lymphatic vessels. This is what the cut surface of such a lung would look like, and you can see the chylous pleural effusion dripping off of the lung at the edge of the figure here. This is what it looks like under the light microscope. Again, big dilated regions of what would otherwise be normal locations of normally numbered lymphatics. This is another example of intestinal lymphangiectasia, in this case, of lymphangiectasia, in this case in the intestine. As you know, the capillary structures in the intestine are called lacteals for the simple reason that they take up this fatty material from the intestine laden with chylomicrons, which renders it a milky appearance, hence the name lacteals. And again, here you can see the significant dilation of these structures based on the presence of the lymphangiectasia. At the other end of the spectrum, we have lymphangiomatoses, which is an abnormal number and configuration and structure of lymphatic vasculature. So as we know, the title oma typically confers the notion of a tumor, and these are in fact tumor-like growths of lymphatic vasculature, at least by immunohistochemical characterization, and because they are abnormal in number, they form actual masses that further create problems beyond the non-functioning of the lymphatic vasculature that they contain. So here's an example of a macrocystic lymphangioma from the mesentery, just to show you not only what this might look like, but actually the rather enormous size that these can attain. And this is an example of congenital lymphangiomatosis that is more diffuse, and you can see the effect on the skin itself and the subcutaneous tissues based upon the abnormal lymphatic drainage that is going to be occurring in this limb. This is what lymphangiomatosis looks like under the microscope, and again, big dilated spaces lined by lymphatic endothelial cells that stain specifically with the lymphatic endothelial characteristic. Another example, and again, you can see the dilated subpleural lymphatics, in this case, that are part of this broader lesion, abnormal number and abnormal size. So lymphangiomas are usually slow-growing masses in the soft tissues of the neck, axilla, mediastinum, retroperitoneum, or extremities. They can involve parenchymal organs as well, and very commonly involve the spleen, as I think I'll show you in a moment. And when we look on magnetic resonance imaging, these are well-circumscribed fluid signal intensity lesions, and they're seen on T2-weighted images. So here is an example of multiple lymphangiomatous cystic structures within the spleen. As I said, a very, very common presentation, and this is what the spleen would look like on gross examination. Another example of the pathology, diffuse pathology in lymphangiomatoses, which can either represent an isolated or few well-described lesions, or can be rather diffusely distributed systemic abnormalities of lymphatic development. Lymphangiomatosis is a beguiling problem. We don't understand much about it yet beyond its sheer immunohistochemistry and histopathology, but it is very much related to a broad constellation of other diseases, either coexisting with them or engendering them, and it behooves us to learn much more about this so we can learn about these other conditions. A specific subset of lymphangiomatosis is Gorham's disease, otherwise sometimes known as disappearing bone disease, because the abnormal vascular growth within the cortex of the bone actually causes demineralization of the bone and ultimately bony resorption. This can occur isolated in the bone or associated with other lymphangiomatosis lesions outside of the bone, and this is what the histopathology would look like. So that ends the first presentation, and we'll move on to molecular mechanisms of lymphangiogenesis and lymphatic repair. My understanding is we'll have time for questions and answers at the very end of the session.